Good afternoon. The topic of today is the introduction to the medical evacuation system. Table of contents. First one, introduction. The second one, mass casualty incident management. The third one, incident command system. The fourth one, medical response to disasters, which includes search and rescue, triage, definitive medical care, medical evacuation, echelons of medical care. So, introduction. Disasters follow no rules. No one can predict the complexity, time, or location of the next disaster. Traditionally, medical providers have held the erroneous belief that all disasters are different, especially those involving terrorism. All disasters, regardless of etiology, have similar medical and public health consequences. Disasters differ in the degree to which these consequences occur and the degree to which they disrupt the medical and public health infrastructure of the disaster scene. The key principle of disaster medical care is to do the greatest good for the greatest number of patients, while the objective of conventional medical care is to do the greatest good for the individual patient. Natural disasters, man-made disasters, and terrorism encompass the spectrum of possible disaster threats. Terrorism, not surprisingly, is the most challenging for medical providers. Weapons of mass destruction creating contaminated environments will be the greatest challenge of all. A consistent approach to disasters, based on an understanding of their common features and the response expertise they require, is becoming to accepted practice throughout the world. This strategy is called the Mass Casualty Incident (MCI) response. MCI response have the primary objective of reducing the morbidity, like injury or disease, and mortality, in other words, death, associated with the disaster. All medical responses need to incorporate the key principles of the MCI response in their training, given the complexity of today's disasters. Mass casualty incident management. Mass casualty incident (MCI) are events that cause casualties large enough to overwhelm the medical and public health services of the affected community. The severity and diversity of injuries, in addition to the number of victims, will be major factors in determining whether a mass casualty incident requires resources from outside of the community. Today's complex disasters, especially those disasters involving terrorism and weapons of mass destruction like chemical, biological or nuclear, may result in an austere environment. And austere environment is a setting where resources, transportation, and other aspects of the physical, political, social, or economic environments impose severe constraints on the availability and adequacy of immediate care for the population in need. Similar to the ABCs of trauma care, disaster response includes basic medical and public health concerns that are similar in all disasters. The difference is the degree to which these responses are utilized in a specific disaster and the degree to which outside assistance is needed to perform the ABCs or disaster care. Medical concerns related to MCIs include four elements: search and risk, triage and initial stabilization, definitive medical care, evacuation. Public health concerns related to MCIs include water, food, shelter, sanitation, safety and security, transportation, communication, disease surveillance, epidemic and epidemic diseases. Both medical and public health disaster response activities are coordinated through one organizational structure, the Incident Command System. Incident Command System, in other words, ICS. Many different organizations participate in the response to a disaster. The Incident Command System ICS was created to allow different kinds of agencies like fire, police, emergency medical services, and or multiple jurisdictions of similar agencies to work together effectively in response to a disaster. The ICS uses a common organizational structure and language to achieve this goal. ICS structure and hierarchy. The organization structure of ICS is built around five major management activities. Not all activities are used for every disaster. Incident command, operations, planning, logistics, financial or administrative. Important principles. An important part of disaster planning is the identification of the incident commander and other key positions before, I have repeated, before a disaster occurs. ICS must be started early before an incident gets out of control. Medical and public health responders, often used to working independently, must adhere to the structure of the ICS in order to avoid potential negative consequences, including death of personnel due to lack of training, lack of adequate supplies to provide care, staff working beyond their training or certification. The structure of the incident command system is the same regardless of the nature of the disaster. The only difference is in the particular experience of key personnel and the extent of the incident command system utilized in a particular disaster. For example, the safety officer varies by the type of disaster: biological incident, infection control expert; chemical incident, hazardous material expert; radiation incident, radiation detection expert. Medical response to disaster, search and rescue. The local population near any disaster site is the immediate search and rescue resource. Many countries have developed specialized search and rescue teams as an integral part of their national disaster plans. Members of these teams receive specialized training in confined space environment. Search and rescue units generally include a cadre of medical specialists, technical specialists knowledgeable in hazardous materials, structural engineering, heavy equipment, operation and technical search and rescue methods, listening equipment, remote cameras, trained cannons, that's mean ducks, and their handlers. Field tip. Local construction companies may be valuable search and rescue assets by providing equipment, tools, and even wooden planks that can be used as stretchers at the disaster site. Casualty collection site. Casualty collection sites for level 1 and level 2 triage should be located close enough to the disaster site to offer rapid treatment, but far enough away to be safe. Important features are proximity to the disaster site, safety from hazards and upwind location from contaminated environments, protection from climatic conditions, easy visibility for disaster victims, convenient exit routes for air and land evacuation. Triage. Triage is the most important mission of any disaster medical response, regardless of the nature of the mass casualty incident. The objective of conventional triage is to do the greatest good for the individual patient. The objective of disaster triage, field triage, is to do the greatest good for the greatest number of people. Field medical triage must be conducted at 3 levels. On-site triage level 1, medical triage level 2, evacuation triage level 3. On-site triage or level 1. Rapid categorization of victims with potentially severe injuries needing immediate medical care where they are lying or at a triage site. Personnel are typically first responders from the local population or local emergency medical personnel. Patients characterized as acute or non-acute. Simplified color coding may be done if resources permit. Acute is mean red. Non-acute is mean green. Medical triage level 2. Rapid categorization of victims at a casualty site by the most experienced medical personnel available to identify the level of medical care needed. The greatest good for the greatest number of people. Knowledge of the medical consequences of various injuries like burn, blast, or crash injuries or exposure to chemical, biological, or nuclear weapons is critical. Color coding may be used. Red, it means urgent. There are casualties who require immediate life-saving interventions, airway, breath, circulation. Yellow color is mean delight or expectant. There are casualties who do not require immediate life-saving interventions and for whom treatment can be delayed, and casualties who are not expected to survive due to the severity of injuries complicated by the conditions and lack of resources. Green color, minor, individuals who require minimal or no medical care. Black, deceased. Triage sieve. The triage sieve can be used at the scene of major trauma and involves a rapid assessment. Can the patient walk? If yes, it's mean priority 3, green color. If no, priority 1, red color. Is the patient breathing? If no, even after opening airway, it means he's dead. Yes, after opening airway, priority 1, red color. If yes, without resuscitation, priority 2, yellow color. What is the respiratory rate? Above 30 per minute or less than 10 minutes, priority 1, red. 10, 30 minutes, priority 2, yellow color. What is the pulse rate or capillary relief time? Less than 40 or more than 120, or capillary relief time greater than 2 seconds, priority 1, red. Between 40 and 120, or capillary relief time less than 2 seconds, priority 2, yellow. Evacuation, triage, level 3. Level 3 triage assigns priorities to disaster victims for transfer to medical facilities. Goal is appropriate evacuation by land or air of victims according to severity of injury and available resources. Some medical personnel, as in level 2 triage. Definitive medical care. Definitive medical care generally refers to care that will improve rather than simply stabilize a casualty's conditions, surgery or other care provided in hospital. Requirements for definitive medical care will vary widely depending on the magnitude and epidemiology of the disaster. In some disasters, local hospitals may be destroyed. Transportation to medical facilities might not be feasible, or the environment may be contaminated. In this situation, definitive care must be provided outside traditional medical facilities. Hospital teams with mobile equipment then can provide graded, flexible response to the need for definitive medical care in disaster and key to a successful disaster response. Medical evacuation. Medical evacuation system of measures providing transport of casualties to aid stations and medical institutions with the purpose to get them prompt and possibly comprehensive medical care and treatment, as well as medical care on the way. Medical evacuation system. The purpose of the medical evacuation system is to ensure that the sick and injured are moved quickly through the public health support system. The preponderance of patients who die in disaster do so within minutes due to penetrating trauma and hemorrhage. In order to save lives, prompt localization, resuscitation, and stabilization followed to timely rapid evacuation of casualties is essential. Medical evacuation encompasses. Medical evacuation includes collecting the wounded, casualty assessment, casualty stabilization, sorting or triage, and prioritizing. Reporting location and casualty status, anticipating complications and being ready to perform emergency medical intervention. The benefits of an efficient medical evacuation system are: minimizes mortality by rapidly and efficiently moving the sick, injured, and wounded to a medical treatment facilities (MTF). Quickly clears the site of disaster and bringing the authority to continue his mission. Builds the morale of the patients by demonstrating that care is quickly available if they are wounded. Provides en route medical care that is essential for improving the prognosis and reducing disability of wounded, injured, or ill patient. Additional benefits of an efficient medical evacuation system are: provide timely resupply of medical supplies through the backhaul method using returning ambulances, acts as a carrier of medical records and resupply requests, provides transportation of medical personnel and equipment. Medical evacuation is performed by dedicated medical vehicles and aircraft that are staffed with medical personnel who provide en route medical care. Medical evacuation is conducted using vehicles specifically designed to provide en route medical care. The provision of en route care on medically equipped vehicles or aircraft enhances casualty survivability. Casualty evacuation, in other words, we call it CASEVAC, is a term used by non-medical units to refer to the movement of casualties aboard non-medical vehicles or aircraft. En route care is limited to the equipment carried by the individual providing care, paramedicals, body aid. The decision to use this form of casualties transport is a decision made by the medical authority based on A. Availability of organic medical platoon evacuation assets. B. The number of casualties. C. The tactical situation. Medical regulating is the tool used to identify patients awaiting evacuation to the next echelon of medical care. It coordinates and controls the movement of patients through the echelons of care. And B. Includes the functions of casualty reporting and accountability. Echelons of medical care. Echelon medical care. Public health support is arranged in echelons of care. Each echelon reflects an increase in medical capabilities while retaining the capabilities found in the preceding echelon. Capabilities of each echelon consist of Echelon 1. The first medical care that a patient receives is provided at Echelon 1. This echelon of care includes rendering first aid to the patients, sheltering the patients as well as from inclement weather, designating by special marks the place where a wounded man has been sheltered, sending walking casualties to the aid station, medical evacuation from shelters to supporting medical treatment facilities. Aid men 1, 2, or 3 to a unit must treat the wounded where they fall. For obvious reasons, this treatment can be only of the most elementary nature, simple enough to permit the man of continue with their duties or to keep him alive until he can be evacuated. The aid man performs his emergency functions and moves on with his unit, leaving the wounded and comfortable and protected as possible in a position where the litter bearers can find him and evacuate him to the aid station. Echelon 2. This echelon care is provided at the clearing station, which are operated by the physicians of the medical company. This echelon of care includes emergency medical treatment, including beginning resuscitation, is continued. Additional emergency measures are instituted by to do not go beyond the measures dictated by immediate necessities. Whole blood is available here. Limited X-ray, laboratory, and dental capabilities are present here. Echelon 3. This echelon casualties is treated in a medical treatment facilities staffed and equipped to provide resuscitation, initial wound surgery, and post-operative treatment. Echelon 4. At Echelon 4, the patient is treated in a hospital staffed and equipped for general and specialized medical and surgical care to stabilize the patient for further evacuation out of the theater. Echelon 5. Echelon 5 care is provided by support-based hospital generally located outside the theater of operation. It is the medical evacuation system that moves casualties patient into and through each echelon of medical care provided. Evacuation can be useful in a disaster. There are several indications for evacuation in a disaster. To, de to decompress the disaster area, to improve care for most critical casualties by removal to off-site medical facilities, to provide specialized care for specific casualties such as those with burns and crush injuries. There are also several reasons to delay or defer evacuation of some casualties. These include contaminated casualties, casualties with transmissible diseases, unstable casualties. Modes of evacuation include ground transport, transport by helicopters or small fixed-wing aircraft, transport by large fixed-wing aircraft. Patient stresses of flight. Hypobaric environment. At altitude, cabin pressure decrease and gas trapped in organs expands, possibility causing pneumothorax, ileus, etc. Decreased partial pressure of oxygen. Casualties with impaired gas exchange will usually experience hypoxia. Turbulence and vibration. Patients with unstable fractures, especially spinal, are at greatest risk. Medical equipment can shift in flight or during takeoff and landing. Temperature and humidity. Varying temperatures and low humidity are the norm. Monitor patients' temperatures and use humidified oxygen whenever possible. Okay. Thanks for your attention.